Okay, good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo ng mundo naroon. Welcome to our 233rd episode of the Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and for all those who have just discovered us today, welcome po at sana po matutunan nyo po ang kailangan nyo po matutunan. Very important topic din po, no? Especially there are those that are really looking forward to having children, and ano po ba yung mga, let's say, yung mga more advanced in their careers, medyo inuna po yung kanilang mga careers, ano po yung kanilang mga ways forward and options po, no? I'm talking about the imperative of preserving po female fertility, which has become increasingly relevant in our contemporary healthcare. Marami po tayong mga social dynamics. As we know, marami rin pong mga more, let's say, career-oriented po sa ating mga kababaihan, and at the same time there have been also advancements in medical treatments and growing awareness of reproductive autonomy, ano po. So those things really encompass po in the recognition that frontline healthcare workers, sila po ang most often first point of contact for the patients. They play a pivotal role in identifying kung sino po yung magbebenepisyo sa mga interventions pong ito. So for this week's episode, we will try to address the critical need in terms of a more nuanced understanding of the physiological, pharmacological, and procedural aspects of fertility preservation. We are very fortunate to have distinguished speakers. They are some, if not they are the leading reproductive endocrinology and fertility experts po sa Pilipinas, discussing po ovarian reserve assessment, ano po yung mga hormonal testing, ano po yung mga follicle count na pinag-uusapan, gaano po ito kahalaga, ito pong mga ultrasound na kailangan po, and how do we elucidate the various fertility preservation techniques na meron po tayo na, yung mga sinasabing nag-freeze ng eggs, cryopreservation po, no? Ano po ba yung indications noon? Lahat po ba ay pwedeng magganon? How early can you do that? Ano po yung potential outcomes patungkol sa mga ito? Ano po yung impact ng mga medical conditions kung meron man sa inyong fertility, female fertility po, no? And then ano po yung mga kailangan ng mga therapies, or kunyari meron pong mga, let's say, may mga pasyente po na may cancer but is still of reproductive age, at gusto pong magkaroon ng kanilang anak, sila po ba ay may pag-asa pa rin po bang magkaroon ng ng anak patungkol po and ma-preserve ang kanilang fertility, and also especially mga ethical considerations, yun po talaga yung mga main topics around this particular study area, which is fertility preservation po, no? This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during a regular Friday. Also my pleasure and honor to host this program together with Dr. Stella Mariose. Ma'am Stella.
Uh, Good afternoon, Dr. Raymond. Welcome to all our participants here in the live broadcast of the Zoom webinar, and to all those watching via live streaming on the TV YouTube channel, as well as the UP System Facebook page, the TV UP Facebook page, and also, of course, the watching from TV UP Signal TV channel 101. Our panelists for today are our esteemed professors, Dr. Virgilio Joy Novero and Dr. Gladys Tanangonan. So you have seen our opening billboard for our program. It is now called Health Updates. We have done a little bit of reformatting for our program, but we have maintained the same high quality, then leveling up to take a closer look at the existing and emerging health problems in the Philippines and in the rest of the world. So for 2025, we want to get immediately to the heart of the discussion, because our program is now only 1 hour. But before we go to our presentation, Raymond will introduce our person on the street video.
Thank you, Ma'am Stella. For our person on the street video po, no, just a reminder, especially for those who are joining us for the very first time, this where we take the pulse of common folks on the street. Ano po ba yung alam po nila patungkol dito sa topic po natin this week? And then really making sure that we get relative sense po, no, kung ano po yung kanilang pwedeng maiambag patungkol po sa discussion na ito. The questions that we pose to our interviewees are as follows. Alam po ba ninyo kung paano pangangalagaan ang inyong sarili upang patuloy na maging fertile? Alam nyo bang pwedeng iimbak or store or deposit ang inyong eggs? At ano ang paraan po na alam po ninyo patungkol dito? Ano po ang opinion ninyo tungkol sa pag-store or pag-imbak ng itlog or your egg cells po, no? At sa palagay po ninyo, ano po ang advantages ng pag-imbak ng inyong or pag-store ng inyong eggs? At alam nyo bang pwedeng magkaanak kahit nagka-cancer na ang isang babae? Please watch this.
I always associated care for my fertility with just overall well-being. So eating well, having a good lifestyle, that will correlate to good fertility.
I eat well. I make it a point to eat all the vegetables that I can. Stay away from sugar. I walk and I swim and I do stretching.
In order to take care of myself, I have to eat healthy, I have to exercise, and I have to take care of my wellness.
I am aware, but I'm not aware of the full extent of the process. But I know that you get screened, they're going to assess your eggs. I know there's a long, grueling process of having injectables, so it's like to regulate your hormones before they extract your eggs.
I've heard about that because I've actually spoken to people who have done that. I've heard that it's safe, but the point of concern that I have is that the process of injecting the hormones can really affect the woman in terms of mood swings.
I knew this from my mentor in med school. You can freeze your eggs there. Parang you can enroll in their program. And then basically, parang sinabi niya lang na about the payment. So I'm also aware, like parang you have to pay initially 50 to 100,000 pesos. And then you have to pay like a yearly maintenance fee so that they can keep storing your eggs.
I think storing or freezing your eggs is a good option for women, especially now that women are more career oriented. They may not be able to have children earlier, as was the trends before. Main purpose of freezing eggs is to preserve the quality of the egg. So the younger you are, the better quality your egg is.
I know that it prepares the woman's body to ovulate. And I also know that it's more intense because it's meant to assure the harvest of fertile eggs.
So yeah, there are a lot of benefits, but again, there's a lot of factors that go into it. Just because you freeze your eggs doesn't mean that you can and will definitely get pregnant 100% at a later age.
Personally, I am more in favor of the natural way of doing things because I'm aware of the side effects that this can cause on the body, physiologically and emotionally.
Do whatever they want first during their 20s, and then by freezing their eggs, parang they have the opportunity to think about having kids later on in their life.
I would not judge it except in terms of safety. And I've heard that it's quite safe for women. So beyond that, I think it really depends on the woman's vision for herself and the child.
Personally, I would love to freeze my eggs because I'm in medicine, so but again, I haven't explored that option yet.
I think for me, that feeds into my realization that it is better when the journey is by two people rather than by one.
Very interesting ang kanilang mga reply, no, Raymond?
Yes, ma'am. Opo.
Oo.
Something that ano po, no, I think they have a pretty good sense based on what they have heard, based on what they have maybe seen or read po, no. But there really is ano po, no, I think there's a need for more information to be provided to them, and sana po mas marami pong silang mapulot dito sa ating webinar for today, Ma'am Stella? Before we proceed lang po, no, certificates of attendance will be given to those who have watched at least 50% of the webinar duration. Our webinar today, again, we'll have a standard panel discussion format. Our speakers will present, and then that will be followed by a standard Q&A session. So if you have any questions that you have prepared beforehand, you can put them in here, dito po sa Q&A box po natin, dito sa Zoom or sa comment section po sa Facebook at sa YouTube. So we'll get our webinar underway. Dr. Stella Jose will introduce our main speaker for today.
Our main speaker is Dr. Virgilio Novero Jr. He is a Professor 5 and in the Division of Reproductive Endocrinology and Infertility, Department of Obstetrics and Gynecology, UP College of Medicine. He is also the Scientific Director for Advanced Reproductive Medicine and Infertility at the St. Luke's Medical Center Global City. He is the founding president of the Philippine Society of Fertility Preservation. So let's give the floor to Dr. Novero.
Thank you, Dr. Jose. Thank you, Dr. Sarmiento. I'd just like to open my slides. Okay, and special thanks to the organizers of TVUP, especially Vice President Alfonso, and again, Dr. Celos, my colleague at the Department of OBGYN. My topic is female fertility preservation, based on the responses at the start of this episode. We heard that most really think that fertility preservation is about egg freezing, but there's a little bit more than social egg freezing. So we'll get into that. So these are my disclosures. I have no conflict of interest for this talk. And this is the outline that we will follow. We'll talk about the emergence and scope of female fertility preservation, the categories, the strategies, and the barriers that are there regarding the implementation of female fertility preservation. So the process of saving or protecting oocytes, sperm, or reproductive tissues so that one is potentially able to use them in the future and conducted because of a current threat is fertility preservation. That's for both male and female, but we're here only to talk about female fertility preservation. So it's only saving eggs, embryos, and ovarian tissues because of a current threat. Okay? So this is an exciting new field. This is probably only about 12 to 15 years old, but it only caught up here in the Philippines the past 5 or 6 years. So the history went like this. So in the 70s to the early 2000s, there was really a progressive improvement in cancer therapy, improving cancer survival rates. At the same time, there were also a lot of developments in the field of assisted reproductive technology. And in this case, the development was really in the field of cryopreservation. Because of these two co-developments, they found the need to merge these two fields and form international societies of fertility preservation in 2006, 2008. And another 5 years or so later, they expanded it beyond cancer. Though it now includes non-oncologic and social indications for fertility preservation. So I think we need to start off with the first category, which is for females diagnosed with cancer. And the reason why this came about is because of this group. Though they found out that the 10-year cancer survival rate over those several decades doubled. And this was present in both adult women and adult and children, where survival rates after cancer treatment had already reached about 80 to 90%. So there were a lot of survivors coming out. And when you have survivors, there were survivorship issues, quality of life issues. And among the most concerning for them, for these young women who survived cancer, is infertility. They found out that they were infertile because they were exposed to toxic drugs and radiation, depending on the type of chemotherapy, and the extent of the radiation, it would affect their fertility. Their ovarian reserve would go down. If you go through the different types of chemotherapy, you could classify them into high risk, intermediate risk, and low risk. So just by looking at the type of chemotherapy that they'll be going through, you could predict what will potentially happen to their fertility. The same thing also with radiotherapy, depending on the plan for treating their cancer. If it is due for radiotherapy, you can also predict to what extent their fertility will be affected. And it's even worse in radiotherapy because with radiotherapy, it does not only affect the egg, but it may also affect the uterus, their site of implantation. So what they decided to do was, instead of having the patient go straight to cancer treatment, they will take a side trip, do fertility preservation before they do their cancer treatment. Put this on the side, they go through cancer treatment, after which, and hopefully they survive. And when they do survive, they have something, a backup, a plan B, in case they will not be fertile. So that's how fertility preservation came about, because of cancer. And because of that, the leading international groups on fertility and on oncology came out with joint statements that patients who would be facing gonadotoxic chemotherapy or radiotherapy should see their fertility doctor for possible fertility preservation treatment. Now, based on census, for adults, 50% of patients with cancer who undergo fertility preservation come from breast cancer. Another 25% will come from hematologic cancers, and the rest is a sprinkling of gynecologic cancers and other types of cancers. For girls, pre-pubertal girls, this would generally be composed of hematologic cancers or benign hematologic diseases and a few others. So that takes care of the cancer category, but there are three other categories that will require fertility preservation, and I'll need to go through them. The second categories are females with benign disease who have a risk for premature ovarian insufficiency. So what are these categories of women? Those with autoimmune diseases, because they will be exposed to immunosuppressive therapy that might affect their fertility. Okay, some with benign hematologic conditions who will be requiring a stem cell transplantation, in which case, when they undergo that, they need to undergo gonadotoxic chemotherapy. So these include your sickle cell anemia, thalassemia, plastic anemia. So they will undergo cyclophosphamide therapy, in which case their fertility will mandatorily decrease. Another one are your medical conditions, which includes genetic conditions. For an example here is Turner syndrome, where the ovaries become fibrotic as they grow older. And finally, you have benign gynecologic diseases. The most common of this is endometriosis, where there is a progressive decrease in your ovarian reserve if there is endometriosis in the ovary. Because of repeated inflammation, your ovarian reserve decreases. So for all of these types of non-oncologic diseases, we will give examples. I will give an example for these. For instance, for endometriosis, which is the presence of your endometrial tissues outside the uterine lining, this becomes significant only, of course, if the endometriosis goes to the ovaries. What happens here? Because it's progressive and because it might be recurrent, you may have recurrent surgery. You may have your ovarian reserve dropping down so low. So they've identified that in patients with ovarian endometriosis, if you have bilateral endometrioma and those with at risk for or have history of multiple surgeries, you might be indicated for fertility preservation. Another is Turner syndrome, which is a disease with 45XO, 90% of which are infertile, but 10% of them, which are your mosaic Turners, may potentially get pregnant. But again, over time, as they grow older, they will develop fibrosis with their ovaries before they reach adulthood. So before that happens, let's do fertility preservation so they have a chance for future fertility. And then we have your benign hematologic diseases. I began to talk about this. You have your thalassemia, sickle cell anemias, plastic anemia. Some of these are really severe and happen in pre-pubertal girls. So when this happens, they might need your hematopoietic stem cell transplantation after receiving alkylating agents, which destroys their fertility. So what you need to do here is you need to collect the fertility, you have to do the fertility preservation procedure so that they have a chance for future fertility. And just to give you a case in point, in these two cases that I'm citing, both with hematologic disease, one is sickle cell anemia, the other one is beta thalassemia, it was so severe that they needed hematopoietic stem cell therapy. They collected the ovarian tissues when they were 8, 9 years old. So they went through the chemotherapy and they went through transplantation. And when they got older, when they became adults, they married, they wanted to have kids. So they got back their ovarian tissues and they got pregnant. So there's that system of freezing your ovarian tissues for over a decade, and then you can have a chance for pregnancy in the future. Let's go to the third category, which are your transgender patients. These are your patients who are assigned female at birth, and we call them, if they want to be reassigned as men, called trans men. So in this category, these patients should first be counseled about fertility preservation before they undergo medical and surgical. They go their medical and surgical transition, so that their fertility will not be affected. So again, these patients will be undergoing the procedure so that before they take on these harmful hormones for them, they have something on the side, because they would say, I would want to have my genetic child, not just from a donor. So this is what you need to do. So again, you can do embryo cryopreservation, egg cryopreservation, or ovarian tissue cryopreservation for these types of patients. The fourth category is what you probably know, and as we heard in the interviews before we started, these are women who request oocyte cryopreservation because of age-related fertility loss. So, as you know, fertility is not it's not infinite, it is finite. Fertility declines gradually until age 37, quite rapidly beginning then. So it becomes a very, very steep slope after which. So before you reach the age where your fertility will decline, they suggest that you should be doing fertility preservation, or social egg freezing. There are two categories of candidates for this. Those one group are single women without a partner, but anticipating that they will meet Mr. Right in the future. So before her fertility declines, I'll store my eggs. The second group are single or married women who deliberately postpone their future because of, say, career or professional targets, or they are in training. I had a patient before who said, I'm going into law school and I know I will never able to have a relationship there. So I want to store my eggs. So career comes first. So they are candidates for oocyte cryopreservation. So this procedure is ideally done at age 30 to 35. And there's a variable assignment of chance for live birth per egg, depending on the age. Usually it's about 5%, but it can be lower or higher, depending on the age. Again, it is not an absolute guarantee for future pregnancy, but it gives you some sort of plan B in case you meet Mr. Right, or you decide to try to get pregnant at a late age where your chances are already low. Besides, based on studies, only 10 to 39% of frozen eggs are actually used. So what do we need to do? We need to inform our patients regarding the impact of the threat on their fertility, what are the fertility preservation options, and the infertility procedures that we can do to help them with their problem. So there is actually male and female fertility preservation. So this topic is only about female fertility preservation. So in prepubertal girls, we only have ovarian tissue cryopreservation, and we already talked about that. But in post-pubertal women, we have 8 different approaches that we can do. Those in green are established methods. Those in orange are still experimental. And we will be going through these briefly. So this is a general diagram, but I think it's a bit confusing, just to show you that these 3 are accepted methods of fertility preservation for women. You have your ovarian tissue cryopreservation. Later on, when you use your tissues which are stored, they become transplanted back. So it is OTC and ovarian tissue cryopreservation and transplantation. You also have your oocyte cryopreservation and your embryo cryopreservation. In your embryo and oocyte cryopreservation, they follow essentially the same steps. So in oocyte, they undergo controlled ovarian stimulation with fairly high levels of hormones to try to wake up as many eggs as possible within reason. And those that we collect at mature stages will be stored as mature eggs. Those women with a partner, meaning they have a sperm available, will be used to fertilize the eggs where they will be storing the embryos. It will be better that you store embryos compared to eggs because the thawing potential is much better with frozen embryos over eggs. And the process that you do to stimulate the ovaries is quite complicated. I'll not go into much detail, but normally we start with on day 2 of the cycle and takes 2 weeks. But sometimes when you have a cancer patient, you do not have the time to lose and you want to start right away. The longer you wait, the cancer might progress. So what you do is there's a possibility of doing a late follicular state start or luteal start, meaning you can start at any part of the cycle now, called random start simulation, and the results are the same. You can also use GnRH agonist. This is a drug which is used as a fertility protectant during the time of chemotherapy or even radiotherapy. The idea here is that when you make your patient sort of in a semi-menopause state and the eggs are, the cycle is not active, then they will be protected from the effects, the negative effects of chemotherapy. But it's not really as protective as some others would claim because this is still a very controversial topic. I mean, the efficacy of GnRH agonists as an equal of the first 3 topics that strategies that we talked about. So for the moment, we cannot accept this as a fully acceptable method of fertility preservation. So they should not be used to replace accepted fertility procedures, but may be co-administered in case the patient is not capable of undergoing the 3 mentioned procedures a while ago. So this one becomes something that they settle on doing with the hope of protecting their fertility. So let's talk about a little bit more about ovarian tissue cryopreservation, which is not experimental anymore as declared by the American Society for Reproductive Medicine in 2019. Here, what you do is you collect you collect whole ovaries, you take out the medulla of the ovary, and you're left with 1 by 2 cm strips. And these ones are only 1 millimeter in thickness because it's only in the outer 1 millimeter thickness of the ovarian cortex are most of your follicles. So you freeze them, kept them freezing, and when you need them in the future, you thaw them and you transplant them in the part of the anatomy of the woman which is available. You can, if the ovary is available, you can put them in the ovary, or you can put them in the peritoneal surface in the fossa ovarium or other areas. So again, there are many techniques of transplanting them. There are even those who transplant them in the forearm, because the ovarian stimulation is systemic. But when you put them in the forearm, you have to do in vitro fertilization. So there are problems though with ovarian tissue cryopreservation, and one of them is cancer seeding. Remember, these patients have cancer, and among the cancers that we know that are at high risk for cancer seeding if you transplant the tissue that for ovarian tissue cryopreservation, highest with a high risk for seeding is leukemia, neuroblastoma, and Burkitt's lymphoma. The other types have a lower risk, like advanced breast cancer. Low risk is your early breast cancer. Regardless of the risk, if you need to do it, there are methods that are now being studied on how to try to mitigate or lessen the risk of cancer seeding. Another problem with ovarian tissue cryopreservation is that not the entire tissue or 2x1 tissue that you transplant will maintain all the follicles that are supposed to be there. You lose 80%, only 20% are found to be remaining after counting the initial follicle pool. However, when they do implant and when they take with revascularization, the grafts may give the patients the capacity to have menstrual cycles and ovulate and menstruate for several months or even years. So once you transplant them back, the expectation is if it works, you will ovulate and menstruate in 3 or 4 months. Another strategy is in vitro maturation. So this involves the retrieval of mature oocytes and maturing them in vitro. So if you recall our IVF process or social egg freezing process, we give medications until harvesting them as mature eggs, and then we freeze them. But in vitro maturation, we harvest the eggs even though they are immature. So we don't give them high doses of hormones to make them mature. We collect them as immature and mature them in the lab. This is much cheaper and simpler, but for the moment, the success rates as compared to standard IVF are not equal. So many are still studying the complete procedure. That's why it's still experimental. Another type of fertility preservation is fertility sparing surgery, and this is described for early stage gynecologic cancers. Again, the basics, I will only tackle the basics, not the details, but there's a standard of care that we expect for cervical cancer, endometrial cancer, ovarian cancer, and borderline ovarian tumors. So there are expected surgeries for them or procedures. But if you are in their early stage, you can do a fertility sparing surgery to give them a chance for future fertility. But however, you're taking with you a little bit of risk, a risk for recurrence and a risk for fertility, for disease progression. So when in these cases, there are sub procedures that will be done instead of the standard of care procedure, and pregnancy rates are here as described. Then you have your ovarian transposition, so patients who will be receiving radiation therapy where they will be hitting the ovaries, kawawa ang ovaries if they're hit by radiation. So you can transpose them away from the field of radiation so that in 65 to 90% of the time, ovarian function is maintained after the cancer radiotherapy. Now I start talking about two very innovative procedures to try to extend fertility preservation. So the first one is platelet-rich plasma or PRP therapy. Here, you may have heard of this before, but probably being used in derma, where they try to inject it in the hair follicles para dumami yung buhok. Also, in making your skin in your face look much nicer. Those are accepted there. But in OBGYN, we're starting to see how this works to try to improve fertility. So it uses the regenerational capabilities of the platelets and the growth factors from plasma. So after you collect blood, take away the red blood cells, you have the plasma, you can inject it into your ovaries, which have these factors, and they contribute to the angiogenetic, immunosuppressive, and regenerational processes for fertility. And with that, they found that in the latest meta-analysis, it seems to be an effective procedure for improving several key fertility parameters in women with poor ovarian reserve. However, evidence is not strong. They're only based on observational studies. We have low power evidence. And finally, we have stem cell therapy, which is used for premature ovarian insufficiency or poor ovarian reserve. Again, here what you use is the stem cells from the umbilical cord. Usually, when they have soluble factors and chemokines that result in regeneration and immunomodulation. And what we do is, again, we inject them straight into the ovary. There are two functions that they will do. They will provide immunomodulation, and they will also do regeneration. And mind you, for regeneration, it is possible to reprogram the cell, which is supposed to be headed for something else, into oocytes. So when they become oocytes, then you have more egg cells available. Again, this is very experimental at the moment. So let's talk about what we need to do. What are the barriers? What keeps us from implementing all of these? So as far as cancer is concerned, based on the 2020 data, we have 152,000 cases of cancer in the Philippines, but only 10% of them are potentially in the younger age group, in the reproductive age group. That's about 15,000. Half of them in males, half of them in females. So for among females, you probably need 8,000 who will require fertility preservation among women. So what are the barriers for pursuing fertility preservation? Multiple, but the biggest are the healthcare professionals themselves. They have wrong information. They are not aware that fertility preservation procedures are available, or they have a certain sense of urgency, especially the oncologists. They want to carry out the cancer treatment right away because they want to nick the cancer in the bud, nick it in the bud. So, but they must also realize that if we allow a chance for fertility preservation, as long as we do not interfere with the timetable for cancer treatment, then it will not affect the results of cancer treatment. Also, the patients themselves, they avoid discussion because they're overwhelmed by the cancer and they are unaware that with fertility preservation, they may not be necessarily a hindrance to cancer treatment. And of course, financial barriers. Probably this is an even bigger factor because of the cost required in fertility preservation. We have here a checklist of information that needs to be imparted to our patients by the clinicians, including the impact of the disease or the threat on reproductive function, on fertility treatment, on the options that we're available to do, the cryopreservation method, and the chance for pregnancy. All of these we need to impart to patients so that they can reach a reasonable decision regarding their need for fertility preservation. And when they do come out after all the treatments, they study that patients who are properly counseled will have a lower regret scale and a higher satisfaction scale if they were properly and fully counseled regarding fertility preservation. Many would say, I was never counseled about fertility preservation. Now I don't have a chance for having a baby after cancer treatment. There are other gaps. The scientific gap is awareness. Structural gap is to be done by the doctors and the administrators who conduct fertility preservation. And the tactical gap, these are with regards to financing. So these are the major problems with fertility preservation. But we need to bridge the information gap among us, among the doctors, especially the oncologists. Oncologists usually don't have the time, and their concern is to save life. So the staff of the oncologists may be the ones to impart the knowledge. They should not withhold the information. They will not necessarily delay cancer treatment. So the solution is really a multidisciplinary approach in counseling and imparting these messages to our patients. We did a local study on the knowledge, aptitudes, and practices of Filipino oncologists regarding fertility preservation. And we found out that there was a significant amount of awareness, improvements in awareness campaign and imparting knowledge to oncologists regarding fertility preservation. They heard about it, but they don't know about it, which is the reason why much has to be improved. To do our fertility preservation, we need IVF centers. for much of the accepted reasons, much of the accepted strategies, I mean. So there are 9 IVF centers locally and more in Luzon, one in Cebu, one in Davao, but this will change very, very soon. We have probably somewhere between 2 to 5 that will be setting up in the next several years. And finally, we sought the help of government when they made the National Integrated Cancer Control Act of 2019. We were lucky to be in the proper timing. We were able to include fertility preservation to be included in the Integrated Cancer Control Act of 2019 so that in the process of cancer treatment, fertility preservation can be included. And for instance, in the treatment of breast cancer, PhilHealth now provides 1.2 or 1.3 million per breast cancer patient. We can request a bit of that 1.3 million for fertility preservation for these patients who are potentially going to benefit from them. That was my last slide. I'd like to summarize now. Fertility preservation has emerged as a new field harnessing the benefits of cancer therapy and reproductive medicine, plus other non-oncologic illnesses to give hope for future production. This new field encompasses both oncologic and non-oncologic reasons to cryopreserve reproductive tissues for future use. There are established methods and there are experimental newer techniques under study to maximize and optimize future fertility. We know there are barriers and gaps to try that hinder our work for fertility preservation, but we're working on them right now. Thank you very much.
Okay, thank you so much, Dr. Joy Novero. Very important and salient points have been discussed. Maraming salamat po. Ma'am Stella, your comments?
Thank you. Thank you for that enlightening lecture, no. It's not really hindi siya ganun ka. It's a very wide field and so many things can be developed. Sige, mamaya may question ako pero meron pa tayong second speaker.
Okay. Thanks. We'll call you again, Dr. Novero, during the Q&A session, sir. Maraming salamat po. Okay, just a reminder lang po, no, those who would want to put in your questions, you can type them in here sa Q&A pod natin dito sa Zoom or in the comment section sa ating UP system or TVUP Facebook pages or in the TVUP YouTube channel. Okay? We'll do another shout out later on po, no? But for now, we'll call in our reactor for today. She's Associate Professor 3 at the Division of Reproductive Endocrinology and Infertility, Department of Obstetrics and Gynecology at the UP College of Medicine, Philippine General Hospital. Also, she's a board member of the Philippine Society for Fertility Preservation. Please welcome Dr. Gladys G. Tanangonan.
Good afternoon, everyone. So let me just share my slide. Okay. So I would just like to probably hammer on the issues on fertility preservation. Dr. Novero has presented to us the wide picture of fertility preservation, all the different aspects, all the preparation that has to be done, and all the issues also that has to be tackled. But I would like to concentrate on the issues because I believe we have a wide range of audience here who might be able to help us lobby for better positioning for fertility preservation. So one of the issues, limited access and affordability. So we do know that fertility preservation techniques are currently offered exclusively in private centers. So Dr. Novero earlier showed you that we have different IVF centers already in the Philippines, but sadly these are all concentrated in the urban centers and not much in the provinces. Mostly we have 1 or 2 in the major provinces, but the other places in the Philippines still have no access. And also, these are private centers, meaning patients must pay out of pocket, which can be a significant financial burden for patients, especially those who still have to undergo their cancer treatment. So next, lack of public funding. So PhilHealth does not cover the cost of fertility preservation procedures. It's also, HMOs do not cover the preservation procedures. But now, at the Philippine, at our board, the board for the PSFP, the Philippine Society for Fertility Preservation, we're actually working on this. So we are talking to the IVF centers if we can have a sort of package like what they have for the Z package for the breast cancer patients or the kidney transplant patients. If we can have such a package that PhilHealth will also cover, it would be a big help for our patients. No? So hopefully we have people from PhilHealth listening in and the HMO people. Hopefully you can give us some leeway so that we may be able to give our patients chance in having fertility preservation. Next is the geographic barriers. Again, fertility centers are only in certain regions and access may be limited. But hopefully, more IVF centers will be set up, which will give us a more affordable price for those needing fertility preservation. Next is knowledge and awareness gaps. So here you are listening to us today. So hopefully some of you are healthcare providers. So there's limited awareness amongst us. Okay, so while awareness of fertility preservation is increasing, there's still need to improve knowledge among OBGYNs and other healthcare professionals about the availability and benefits of these techniques. So especially this was already discussed by Dr. Navarro, especially our oncologists. Of course, we know your primary concern would be the saving the life of your patients. But we know that with the advances now in the treatment of cancer, there are more survivors. So we should go beyond the treatment of cancer. So the quality of life of these patients are also very important. And then of course, patient knowledge. So with the help of the audience here, maybe you have a kapitbahay, you have a kamag-anak, you have a kapatid who actually needs to know about this, no? So even as patients, when we are the patients, we should learn how to ask. You should be concerned about it, especially among the younger ones, no? Alam ko, ano bang tawag sa inyo? Woke, something like that, no? So you do know a lot, especially in social media, and hopefully fertility preservation would be more discussed now, no? So that options, importance of early intervention can be emphasized. So it would not lead to missed opportunities. Okay. Other challenges, of course, cancer treatments like chemotherapy and radiation can significantly impact fertility, making fertility preservation crucial for women undergoing these treatments. So these are the patients we need to really talk to. So what I would suggest is that hopefully we would have like a tumor board in our hospitals wherein it's a multidisciplinary board wherein you have a psychologist, you have fertility specialist, all of these people coaching these patients on how they should go about their treatment. Okay. And then of course the challenge with pre-pubertal girls, we do know that cryopreservation of ovarian tissue is the only available option for these girls. But there are challenges in providing this service, and there's a need for specialized expertise. And of course, here comes the ethical considerations. So first, who does the decision making? Who gives the consent? Is it the parents? Is it the patient? Should the parents decide for their child? So all of these things are very important issues that we actually need to face when it comes to pre-pubertal girls. Next, of course, would be the ethical consideration. So ethical and legal issues surrounding the storage and use of frozen embryos and oocytes, very important to discuss, particularly in cases of death or separation of couples. So these things need to be addressed. So what happens when the patient dies? What happens to the stored embryos? Okay. And then, of course, we also have the social and cultural factors. So cultural attitudes towards family planning and fertility can influence demand for and utilization of fertility preservation services. So being a predominantly Catholic country, we sometimes encounter barriers in terms of the different procedures that we would do for fertility preservation. So we should all sit down and discuss this. Okay. So in the Philippines, while awareness of fertility preservation methods is growing, accessibility and affordability remain significant challenges. But with excellent survival rates and advances in the field of reproductive medicine, discussing risks for infertility and fertility preservation options with patients diagnosed with cancer or certain disorders at diagnosis is an important component of comprehensive care. So very important, early discussions which allow patients and families to engage in decision and may decrease the potential for regret later on. So I hope today's episode of TVUP has enlightened all of us a bit. Thank you for listening.
Okay, thank you so
Excellent
much, Dr. Gladys
lecture.
Tanangonan. Apa. Yes,
Oh,
ma'am.
excellent lecture from Dr. Gladys Tanangonan. Since we're also running out of time, but I have a question for Dr. Novero, for Dr. Joy Novero. I have a patient who underwent IVF and so she got pregnant and meron siyang stored eggs na naka-frozen. Then so now she doesn't want to have a baby anymore. So what is your advice for patients like this?
Well, that situation does not fall under fertility preservation. They wanted to do fertility treatment, so that
Oo,
it just so happens that they have extra embryos, probably,
oo,
not
oo.
eggs. Now, there's a problem there because normally when we start the process of IVF, we tell them that we will only try to form as many embryos that you will need so that you will not have excess. But if you form too much, you are obligated to use your embryos as much as possible. So if you will not be using your embryos, they will be forever frozen. They will be ever frozen in the tank of the IVF center. So it really is a problem. Uh, what we do in Carmi in St. Luke's is that for patients who already completed their family and they have extra embryos, we keep on reminding them that you have embryos and you should use them. However, if you don't use them, you will lose the right for the disposition of your embryos in favor of the institution, which is St. Luke's. But we do not dispose of them. They will be kept there. We're still waiting for legislation if we can use those extra embryos for an embryo donation. So the key really is to have a good IVF process so that you limit the number of embryos that you will form, so that you do not have too many that are in excess. But sometimes it is quite difficult to do that. Sometimes you can have so many eggs there, and then it so happens that not all of them will develop. It's also possible that you can only have one embryo and then it becomes a pregnancy. So it's quite difficult sometimes.
I have a question for Dr. Gladys Talangonan. Kasi in UP kasi Raymond, yung sixth floor na allot na for them for the IVF center, the sixth floor of the new building. My question is, yung mga charity patients ba, how will they be able to access yung ganitong fertility preservation methods?
Actually, ma'am, we have very good news about that, no? We were promised by Director Gap that they would actually be creating packages for our charity patients. So I think it will be given to them for
Pag-asa.
free.
May
Yeah,
pag-asa tayo.
yeah,
Oo.
yeah.
Yan, for our audience, I hope you heard what Dr. Gladys said, no? So, hindi lang siya para sa mayayaman. Pwede din yung average person, the hardworking people who want to have children. So, the others, no, you can listen to this recording, to this lecture for 1 week next week, no? So, from Luzon, Visayas, and Mindanao, you can review the lecture. And so, mabuhayan ng loob, lalo na yung wala pang children. Back to you, Raymond.
Thank you so much, Ma'am Stella. No questions naman po that I've been seeing. Although there's a question here, say, ngayon lang po napasok, no? Um, ano daw po ang optimum time or optimum age when the eggs should be harvested by the woman? Meron po bang ganoon? Or like a
Yes,
prescribed age, sir?
yeah, I mentioned that in my talk. The ideal is between age 30 to 35. Not too early, because if you collect them too early, chances are you will find Mr. Right and you will not need your frozen eggs. If you get them too late, the quality of your eggs will already be too poor. You will need to freeze too many eggs because quality is poor. So my most ideal is between age 30 to 35.
Okay. I think that's related to another question. Medyo naka-direct message lang kasi sir eh. Kung yung 30 daw po is too late kasi 'di ba parang may kasabihan sir 'di ba pagka 30 ka na parang wala ka na sa kalendaryo or something. Parang gano'n sir. Yeah, how do you address
Not
those
not
cases?
based on current research. Kasi based on current research, if you store them too early, talagang chances are hindi mo talaga gagamitin yon. Parang nasayang lang. Pero mas nagagamit 10 to 40% yung mga nagsusstore between age 10 to 40, between 30 to 35.
All right. I'm not seeing any questions, Ma'am Stella. I think we can go
No,
ahead
no
to
questions.
yes, ma'am, to our last part, which is our evaluation poll. So we're asking everyone, especially here in the Zoom, to answer po evaluation poll that we'll be launching right now. These are 5 statements, 4-point Likert scale. Encouraging everyone, and we will not be closing this until the end of the webinar. I'll read through this, and we hope everyone will be able to answer po. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Again, very, very thankful to the Division of Reproductive Endocrinology and Infertility po, no, of the Department of OBGYN at the UP College of Medicine, Philippine General Hospital. Maraming salamat po. You will see all of the hearts and emoticons that you are seeing here in the Zoom po. Thank you
Thank
so
you.
much to Dr. Novero and Dr. Tanangonan po for sharing their insights, their expertise, and their time for today po, no. Maraming salamat. I'm trying to get a sense po, no, just trying to get a shout out po for those who are watching us all the way from, let's say, locally. Well, Valladolid District Hospital in Valladolid, Negros Occidental, in Oriental Mindoro Provincial Hospital in Calapan City, Oriental Mindoro, Western Visayas Medical Center in
Okay?
Iloilo City, Region 1 Medical Center also in Dagupan, Pangasinan, and Southern Philippines Medical Center in Davao City. Also those from Bataan, the province of Bataan, province of Quezon, Bataan, maraming salamat po, Marilao, Bulacan, from the Bulacan Medical Center, Department of Pathology and Laboratory Medicine, the Pontifical and Royal Catholic University of Santo Tomas Hospital, La Consolacion University in Malolos, Bulacan, First Gen Corporation, thank you so much. Those from Philippine General Hospital, obviously, and those from Rizal Medical Center din po. Maraming salamat. There are those also watching us from University of Rizal System Health Services, as well as those internationally, Dr. Novero and Dr. Tanangonan, those from the Kingdom of Saudi Arabia po. Maraming salamat po. From the state of California po in the United States. University of Hail in Hail, Saudi Arabia. And Ryan Hall Shanex Incorporated in Bridgewater, Canada. As well as the Chonin Hospital in Taipei City in Taiwan. So maraming salamat po. I think this will be very helpful. We have a lot of OFW nurses and others who are watching and trying to get a better sense of the lessons that they are trying to get from these weekly webinars po natin. In the meantime, you'll be able to watch us on the playback at the TVUP YouTube channel and the TVUP Signal TV channel 101. Next week, Ma'am Stella, who do we have?
Our
What do we have
speaker
next
for
week?
next week is Dr. Broly Bansuela. He's he owns the very popular Top Notch. So for those who want to take the board exams, you can listen to his lecture next week.
Ayun. Thank you so much. We'll have Dr. Broly again, but this time as our main presenter. We've already had him as a reactor po previously. Before we conclude our program, all hot updates webinars are archived for viewing at the TVUP YouTube channel. So you'll be able to go to www.youtube.com/TVUPPH. Meron po doon live tab. You'll be able to see all 232 episodes of our program. After today, it will be 233. Also, there is a shorts tab in the same YouTube channel po, no? Wherein we select presentations po, feature them in snippets, and then show them in YouTube Shorts. So we hope you'll be able to gain nuggets of wisdom from this YouTube Shorts po natin culled from our webinars. Okay, this formally closes our webinar for the week. Magkita-kita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.
Okay na, Stella, we can go.
Oh, pwede na. Thank
Okay,
you.
thank you.
Thank you,
Thank
Joy
you.
and Gladys.
Thank you. Thank you, Raymond. Thank you. Si Mambian, thank you.
Thank you, Dr. Novero and Dr. Tanawanan.
All right, thank you. Thank you, Gladys.
Bye, sir.